Welcome to Season 2 of Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zires from Doc's Dermatology, and each week I'm joined by my residency buddies, Dr. Laura Ferris from the University of North Carolina and Dr. Tim Patton from the University of Pittsburgh, where we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major podcast platforms. The video component, as a reminder to everybody, has some of the key figures and tables from the articles that we talk about. So this week, we've got one of our patented six-pack episodes where we are going to talk about the stuff that we have found most interesting in the literature over the last few weeks. Dr. Ferris, what do you got?
Okay. So I decided to pick this paper on small vessel vasculitis. Why? Because I feel like I'm bad at vasculitis. And two, because they are classified by the Chapel Hill criteria.
Oh.
And I feel like now that I'm in Chapel Hill, I can't be bad at vasculitis. But so maybe I'll be a little less bad.
Okay, fair.
Okay, so this is point of care risk factors for systemic disease in patients with small vessel vasculitis of the skin, Majan et al. And this was data from the Brigham and Penn. So what did they do? They looked at 430 cases of patients with small vessel vasculitis of the skin, and they classified them as either being skin plus systemic involvement, which is 87, versus the 434 who had cutaneous only vasculitis. And so how did they basically had to have a minimum of 6 months of follow-up and to have received a diagnosis of systemic vasculitis. So, and also if they had small vessel vasculitis associated with underlying connective tissue disease, that was considered systemic. Or if they had end organ dysfunction, that was considered systemic.
Wait, tell me those one more time.
Okay. To be considered a patient who had systemic involvement, it was you had in your chart a diagnosis of systemic vasculitis, underlying connective tissue disease associated with that vasculitis, or organ dysfunction.
Okay, so you could have like a creatinine of 1.4 and they would have called it systemic.
Yes, because it would have, because it was, they didn't go into like what was the exact cutoff, but if you had organ dysfunction, that counted.
All right, so
but like renal dysfunction did.
So like if you had HSP and had some GI pain and a little bit of blood in your poop, that they probably called you as systemic. Okay.
Well, you had to have like underlying organ dysfunction. So, I'll go into some of the criteria that would make you go, okay, maybe.
All right.
Okay. So what they did was they looked at odds ratio of having systemic involvement, and they did univariate and multivariable analysis. Okay. Most common vasculitis that they saw was IgA vasculitis, followed by connective tissue disease associated vasculitis, then cryoglobulonemic vasculitis.
These were the most common systemic vasculitis, is not that.
No, of all the vasculitides that was in the cohort.
Okay. Huh.
No, sorry. That was the most common of all of the systemic.
Yeah. Because
yeah.
Okay.
And so multivariable analysis showed the factors that were significantly associated with systemic disease were nausea, vomiting, odds ratio of 3.92. So that tells you, Matt, that's not just like, oh, I feel sick. Oh, it's systemic, right?
Yeah.
Like that was, it puts you over, you had to actually have systemic involvement. Ulcerating or necrotic skin lesions, odds ratio 3.26. Abdominal pain, cramping, odds ratio 2.7. And then fatigue, malaise, or lethargy. And that was odds ratio of 2.6. So if they complain of those, they're more likely to have systemic involvement. In the cohort who had urinalysis, and I'm like, doesn't everybody get urinalysis? But dipstick hematuria of 3 are, and so most of them did. 388 did have UAs, but some did not, whatever that is. The difference under 100. Dipstick hematuria of 3 or more had a 2.4 odds ratio of 2.4. So those were all like the things that were predictive of having systemic involvement. The thing that was inversely associated was recent antibiotic use. So it was like protective for, right? So if they recently had antibiotics and they have vasculitis, it was probably going to be cutaneous only.
So that was probably just a drug reaction to the antibiotic or possibly part of the immune response to the infection.
Yes, that is what I'm taking. And then other things associated with systemic disease in only univariate but not multivariable were joint pain and younger age. So what was not associated, no association with skin pain, blood in the stool, melena, and then trace hematuria or proteinuria on the dipstick. So it really had to be 3+ on the dipstick, and also recent URI did not have an association either way. So, I thought this was helpful. Who do I need to worry about more? Who do I need to be working up more? I personally get a UA in everybody who comes in with cutaneous vasculitis,
Yep.
but now I don't have to worry about trace hematuria as much.
Okay. Do you get the number of people I've ever seen who cutaneous small vessel vasculitis was the initial presenting sign of something meaningful was kind of vanishingly small, right? It's almost always you already know if they have connective tissue disease, you already know they have connective tissue disease or whatever. Like a normal healthy person who gets some small vessel vasculitis just seems, maybe if it's HSP and they had an preceding infection, but that tends to not turn into anything big. What's you guys take on kind of the quote run of the mill small vessel vasculitis patient?
So I think, and again, prefacing, not that great at vasculitis, but I think that for the most part, those are cutaneous limited. I mean, I definitely go look for things, but I have not. I mean, I can't remember the last time. I think I've had like one person who had renal involvement, but I don't feel like I've seen a lot of it. How about you, Patton?
It's not common, but I mean, I can recall the patients with cryoglobulinemia and Wegener's and HSP most commonly.
Was like this
It's
cryoglobulinemia the one, like, was that how they presented though? Was just with skin findings and then it ended up being.
yeah.
Yeah, I guess actually that's true. I have had a couple of those.
Yeah.
Yeah,
I mean, it's rare,
it's
right?
rare.
What were the
Yeah.
numbers in the study, right? It was 70 some that had systemic disease and 400 where it was limited to the skin,
Yeah.
Yes, it was
right?
87 with systemic and 343 with just cutaneous only. So
That
that, I
that
mean, to
that
me, I would
sounds
say
about
like,
right.
okay, that sounds about right to you. I would feel like I see even more that's just cutaneous,
Well,
but
but
yeah.
then if you didn't look that hard and you took out the IgA vasculitis ones, right? So the people who had basically had HSP and had some GI involvement or had HSP and some renal involvement, if you didn't look that hard, their HSP would go away, they'd be fine. And then you'd probably be at like 30 or 40, it'd probably be at less than 10% of people had something systemic.
Yes. So what were,
Yeah.
Tim, of those, like, what were like your worst vasculitis, like systemic vasculitis cases? Like, oh God, I'm so glad I worked this up because blank.
Well, I mean, a guy with Wegener's who was admitted to the hospital with renal failure who refused dialysis and died.
That's kind of
Yeesh.
And
bad.
yeah, but he had leukocyte-classic vasculitis in the skin. Um, and then PAN's not good. Now, some people would say that's not small vessel vasculitis, that's medium vessel vasculitis. That's not palpable purpura. That's more of kind of that reticular pattern with
Yep.
painful nodules. You got to go a little bit deeper for that biopsy. But PAN's bad. I mean,
But it's
yeah.
the big thing is those don't really present with like a whole bunch of little,
No.
6 millimeter palpable purpura
Palpable
spots on your
purpura. Yeah.
ankles. Right. I mean,
Yeah.
that's not, whenever I've
Right.
seen PAN or Wegener's, it's been like you see it and you're like, oh, this is not normal vasculitis.
Yeah, right. I mean, the Wegener's patients that I recall were sick. I had a Churg Strauss. I know we're not supposed to use these names. Eosinophilic granulomatosis and polyangiitis. A Churg Strauss guy that was pretty sick. That was a little bit odd because he kind of had hypereosinophilia for a while, and his skin disease was actually more kind of these urticarial lesions. And then he evolved into EGPA, which that's been described, where it starts off as hypereosinophilic syndrome. But yeah, I think going into the room, if they feel otherwise well, really no complaints, it's probably LCD, and yeah.
Okay.
You got it like
You
a
still
UA,
have to work it up, right? I mean,
hepatitis, CBC. Yeah.
yeah, I
So
do rheumatoid factor, kind of the poor man's cryos before I actually order cryos, because cryos just technically is difficult,
it
and
is.
I don't think I would, if I thought it was cryoglobulinemia and cryo test was negative, I don't know if I would trust that. So rheumatoid factor is kind of my cryo screen before I actually order cryos. But yeah, Hep B, Hep C. I do these C ANCAs. If they're not sick, the likelihood of the C ANCAs being positive is low, but I'll check it. It's an easy test. I think it's cheap.
Okay.
And UA, right?
Mm-hmm.
Do
Okay.
do
You
people?
do chest X-ray or anything like that in these patients, or
Not. I mean, I always ask about lung symptoms. If they don't have lung symptoms, I don't get a chest X-ray.
okay.
Okay.
I do not typically do it either. Just wanted to make sure. And then I didn't want Matt to be the only one who overachieves and does extra. So I just found this one interesting case report. I'd never really heard of it. It's called Recurrent Cutaneous Eosinophilic Vasculitis in the Journal of Allergy and Clinical Immunology in Practice. So it was a woman with 5-year history of intermittent recurrent rashes. It was palms and soles, and then they become painful, and then they become like pruritic purpura, and they would recur every 2 to 3 months. She had an eosinophilia of 16%, which is high. And then biopsy, neutrophil infiltration, nuclear dust, and then prominent eosinophil infiltration.
All right, get to the point, Ferris. Why do we care?
Because I thought like this is not something that I thought like if you I'll give you the slides. It like I look at this and it almost looks like urticarial wheels, and then like they do look like these like deep purpuric things. It was mostly palms and soles, but it just like I wouldn't have thought like this is just a manifestation of vasculitis.
Okay.
And it goes away with prednisone. So I thought, vasculitis with a bunch of EOs, think about this, and you can treat it with prednisone. So because it's not in the Chapel Hill consensus criteria, that's why I care.
All right. Okay. All right. Patton, what do you got? What are you going to talk about?
Yeah, first 6-pack, October 2025 edition of Skin Appendage Disorders, called Dermatologic Implications of Glucagon-like Peptide 1 Receptor Agonist Medications by Burke et al. We recorded an episode talking about GLP-1 receptor agonists a couple of weeks ago, but didn't really get into side effects. I mean, this is a review article. It's not like technically challenging, but more and more people will be using these meds, so figured we could review some of the dermatologic side effects that we might be seeing more of.
I didn't even know
Isn't that a great idea? What's that?
I didn't even know there were any. Hair loss. That's it. You lose too much weight and your hair falls out.
Well, then pay attention. 6% of side effects reported to the FDA were dermatologic in nature. First side effect paper talks about Ozempic face. How could you not include Ozempic face? Okay. Hollowing of the cheeks, sunken eyes, sagging jowls. Seems to me that most cosmetic derms could manage these pretty easily with their various procedures and torture devices. The paper talks about injection site reactions, hives, hypersensitivity. Recommendations include typical recommendations for injection site reactions. They do also mention that switching GLP-1 RAs can be considered because cross-reactivity is not always present. So, okay, I thought that was good to know. Dysesthesia. This was an interesting one. I had not heard about this. Have been reported, and these seem to be more common in the oral version of semaglutide. So Rybelsus, which is FDA approved for diabetes, 3 milligrams daily for 30 days, 7 milligrams daily after that, can go up to 14. Although apparently Novo Nordisk is pursuing weight loss indications at higher doses. And this actually just got FDA approved to treat like prevention of cardiac side effects in diabetes patients with certain risk factors. So it just got FDA approved for that. So the oral version, just something to know that the dysesthesia, that was kind of interesting. A list of very rare reactions, BP, what sounds like age-up psoriasiform reactions, vasculitis. These are so rare that
you don't know if they're actually related, right? You got millions of people on these drugs. Occasionally somebody's going to get something.
Pretty much, right? Paper talks about hair loss, right? So that was what you mentioned. Recent Trinetic study published in the JAD found an increase in TE with tirzepatide compared to other weight loss drugs. But there was another real-world study that didn't find that disproportionality signal for hair loss. And there was even a case report of AGA improving significantly after 6 months of tirzepatide use. So hair loss is confusing. TE occurring in weight loss makes sense, right? Especially if it happened really quickly and they weren't really good at, I think some people like literally don't eat. Like you have to actually counsel them on, you have to have some sort of caloric plan so that.
It was, I've told you guys that I was on, when I went on tirzepatide, which I'm now off, of course, but my first shot, I didn't eat for 3 days. Like literally did not eat for 3 days. It was right at the start of the AAD. So I hadn't eaten for 2 days, show up at the AAD, go out, having some libations. I was so hungover because I hadn't eaten in 2 days. I couldn't leave my room for a day. It was
Wow.
embarrassing.
And your bed was covered in TE hairs. The paper ends with potential uses for GLP-1 RAs in dermatologic conditions, but we kind of talked about that on our previous episode, so I wasn't going to go into that there. So pretty simple, easy paper that I thought
useful.
The dysesthesia was interesting to me. That one I had not heard of.
And I think like 10% of the United States is on a GLP-1. I mean, it feels like it's even more when I look at patients' med lists, but this is a huge proportion of the people in the U.S.
And I think they're going to get cheap pretty quick. I think they're already starting to. And I think it's going to make a huge population health difference. It is really interesting.
One of my residents brought up, this was not in the paper, one of my residents brought up Ozempic butt. Ooh. Have you guys heard of that one?
No.
Is this just like you lost fat, so whatever you have becomes more saggy? Like, couldn't you have Ozempic
kind of
arms? Yeah.
I don't, the butt thing, she said, oh no, it's very like she goes, I think she said they look like pancakes. I'm like, okay.
Okay.
I don't know. It wasn't in the paper. That's just a little side note.
Okay.
I'm going with that from now on. Anytime from now, whenever I take my shirt off, I'm going to be like, well, I've got Ozempic muscles.
This is an Ozempic body.
Yeah.
I look like a giant pancake.
All right, let's go on to my 2 papers that I did for this. Number 1. So there was a study several years ago so the title of the study, an interventional comparative prospective study to determine the optimum concentration of intralesional triamcinolone acetonide in treatment of alopecia areata. So there was a study a few years ago where they looked at like 10 milligrams, 5 milligrams, 2.5 like milligrams per ml for alopecia areata, and found that the lowest concentration that they studied, which was 2.5 mg per ml, worked just as well as the higher concentrations, but caused less problems in terms of like atrophy and that kind of stuff. So these people did a study where they looked at 2.5 mg per ml versus 1.25 mg per ml, and they showed pretty conclusively that if you go down to 1.25 mg per ml, it doesn't work as well. So that was because I've often wondered, like, how low could you go? Could you go down to like 1 mg per kit? But no, 2.5 milligrams per ml is the lowest dose you want to go to for intralesional TAC for alopecia areata. Nowadays, I always kind of hated doing this because it was just. Do you guys still do a lot of? I mean, I guess what the heck else are you going to do for somebody who's only got a little bit of alopecia areata?
Oh my gosh, yes.
Yes, that's like first line.
Oh my gosh.
Come on.
And I still do the TAC 5 because then I can just tell the MA, I'm like, draw 2 saline and 2 of TAC 10.
Okay.
If I had to do the 2.5, they would ask me and I'd be like, it would take me too long. So I still stick with the 5.
3 mLs of saline, 1 ml of TAC.
Yeah.
There you go, Patton.
Girl math.
Well, I know, but that's if I wanted 4 cc's. They'd be like, well, you only want 1 cc? And then how do I do that?
It's fine. I've seen residents not able to calculate it. Not at UNC.
Ferris, that should be part of your.
Can you really not do that? What's
that should be part of your residency interview process. Like
I'll do that.
Have them.
I need 3.5 cc's of TAC 2.5 now. Go.
Right.
Yeah.
I need 2 cc's of lidocaine, 1.8% plus epinephrine, 1 to 487,000. What's the concentration? Meet right now.
I would have to retire. I couldn't calculate that, but
well,
you would know
make the resident do it.
I would already know. Yeah.
The applicant do it, right? That's the idea.
All right. I'll consider that.
That was article number 1. So 2.5 mg per ml. Number 2, this was interesting. So hydrocolloid dressing versus petroleum ointment for scar appearance after derm surgery. So basically, after you do a normal excision, one group they did, you put the petroleum in a dressing over it, you change it every day, the whole thing, you clean it, you put new petroleum on, normal wound care, versus you put a hydrocolloid dressing over it, because hydrocolloid dressings now are really cheap and really easy to get. They're really sticky. So can you just slap a hydrocolloid on there, leave it on for a week, and make it like super easy for people? Well, the takeaway here was that first, in terms of the scar appearance, the ones that got the hydrocolloid dressing looked better at a week, but long term, it made no difference. So the hydrocolloid, it healed a little faster with the hydrocolloid than with the petrolatum, but it made no difference in terms of the actual scar appearance. However, it was very interesting whenever they looked at convenience. So did patients think it was convenient and comfortable? So the hydrocolloid dressings were pretty dramatically higher degree of convenience and comfort compared to changing it every day with petrolatum, and were significantly more comfortable than changing it every day with petrolatum. So more convenient, more comfortable, but none of these things were really statistically significant, but it was only like 60 people in each group. Surgical site pain was higher with the hydrocolloid, so a little over 21.2% versus 12% with the petrolatum. Wound dehiscence was higher. So 4 patients, 6.2% had dehiscence with the hydrocolloid and 0 with the petrolatum. And postoperative bleeding was higher. So 20% with the hydrocolloid versus 20.6% versus 8.8% with the petrolatum. Again, none of those were statistically significant, but if those numbers are real, it just means if you did enough, right? So there was like twice as much postoperative bleeding. There was nearly twice as much surgical site pain.
Infection? Did they look at infection?
Yes, required antibiotics 0 in both groups.
Okay.
So
it's interesting. I like the hydrocolloid dressings, like the Duoderm ultra thin.
Yep.
And so, but I guess I don't really do them with sutures. And I wonder, were they using gut suture? Or were they using absorbable or, like Proline or whatever, non-absorbable? So I could imagine the hydrocolloid would kind of disintegrate gut suture or absorbable suture.
And it depended on the location. So on the face, they used 4-0 monocryl and topped it with fast gut. On the trunk, they used 3-0 monocryl and then maybe 4-0 as a running subcuticular. Those were the sutures they used. I don't use a lot I barely ever use monocryl. So
yeah, I would use it for like ED&C sites, right? So if you just slap that on and leave it on for like 6 days, especially in the summer, people can go in the water, they're waterproof, or even like other old people who are getting shave, or anybody who's getting a shave biopsy on their back, those Band-Aid hydroseals are basically cheap hydrocolloid. And, people are like, I can't change the Band-Aid. I'm like, I'm going to put this on and just leave it. And then at some point it'll just fall off and you're done with wound care.
Yep. And those are cheap.
Or they can swim with it. What's that?
And they're really cheap, like really cheap now.
Yeah.
Do you guys think the Mighty Patches and all of the Mighty Patch type things, do you ever tell kids not the kids asking us, but they're all just using them anyways. Do you think, from watching my kids use them, I think they do make a difference. I think they make acne lesions get better faster.
Yeah. My kids all believe in them. My girls.
Yeah, exactly.
So,
I'll tell people the other place that I think those are useful. Well, we'll get to it in with my next. Well, no, I talked about it last week. The fissures with the fingertip fissures,
mm,
hydrocolloid dressings, which they make Mighty Patches kind of for this, are actually really good for that. They're stickier and more waterproof than Band-Aids, so I think they're actually pretty good for fingertip stuff, and help it to heal underneath there.
okay.
So yeah,
Yeah. Yeah. No, I still think the EDNC site, and especially like on the leg where I'm like, I know all the water is going to run down and get them infected. I really like having it for those. So,
okay.
and then, yeah.
All right, so reasonable to offer to surgery patients as a, would you rather something more convenient or something that's, less likely to be painful or do any oozing or that kind of stuff? So it's worthwhile, new information. All right, let's go. Ferris, what do you got?
Okay, so my next paper is actually gene expression profiling to predict melanoma sentinel node status. This is the MERLIN 001 study. So this just came out like a couple days ago at the time of recording. And so this is a prospective study conducted at 9 academic medical centers with experienced melanoma surgeons. And basically, to be enrolled, you had to be a patient with a biopsy proven invasive melanoma, T1, like high risk to T3 tumor, and clinically negative nodes. All of them got the Merlin test, just to remind people what that is. It's CPGEP. So there's 8 genes. I will not read them all off. We can put them in the show notes. Different. This is very different than like the Decision DX Castle test. And then they also do CP, which is clinical pathologic factors, which are age and Breslow thickness. So you put all that into the model and it comes out as low risk or high risk.
All right, so
Okay.
wait,
So
Ferris,
this was a good, yeah.
hold on. Why did they use Merlin instead of Castle? Is
Well,
one better
because
than the other?
because this was done by the Merlin people to
Ah,
show that how their tests work. So
okay.
this is truly prospective. Like we've got a lot of different, tests out there. This was, what makes it different than what's out there. It's not like we took a series of, 500 people who had sentinel node biopsy. We went back and tested their tumor and now we can classify them. This is like prospectively they did it. Everybody got sentinel node. Everybody got the test. They were blind. Everybody was blinded to the test result and then they unblinded it. Okay. So in the end, in this study, so 1,761 patients, good size, 37% of them had a low risk result. And the other set, whatever that other number is, 63% had a high risk result. So now the big question is, what percentage of those low risk cases were sentinel node positive? So what you would say as your pre-specified endpoint is it should be 5% or less, right? That if, in NCCN guidelines, if the probability of a positive sentinel node is less than 5%, you don't do it. If it's 5 to 10%, you discuss and consider. And if it's greater than 10%, you discuss and recommend. So what they found in this low risk group was that the positivity rate was 7.1%. So that still falls into the discuss and consider. Negative predictive value of like 93%. Among the high risk cases, that 2/3 that were high risk, they had a sentinel node positivity rate of 23.8%. So, it's good that it's this large scale study. If you look at it, the majority of these tumors were kind of thicker tumors. So 40% of them were T2A. There was, among like, if you look at other studies like Castle studies, there's a lot more T1As in there. There was only 26 or 1.5% were T1As in this study. So, if you do look kind of like just among the T1Bs, and you said among those patients who are the T1s, so T1A and T1B, that number was 4.9% of low risk had a positive node. But, that is like just over the edge. If you look at the T1Bs, which is where I think these tests can be the most helpful, it was 5.2% of those patients with a low risk result still had a positive node. So it it was a rigorous, well done. It was a rigorous study with a rigorous endpoint. It did not, however, show that it could really pull out a nice low risk group that could safely forego sentinel node biopsy if you really want that risk to be below 5%.
Interesting. So, like, because it's my initial take whenever I looked at this was like, well, shit, it definitely is telling us something. Like the high risk ones had way more sentinel lymph node positivity than the low risk.
Yeah, it's definitely telling us something. It is definitely saying this group is truly lower risk and the high risk group is truly higher risk. It's just if you want to get down to like what do the NCCN guidelines say, and you want to be able to say you are safe, you really want to be below 5% in that cohort. And the only group that was truly below 5% were T1As, and there's only a couple of them. I don't think most of us would recommend this in a T1A, but T1B was 5.2%. So,
Pat, anything you want to say before I talk about something vaguely related?
No, I mean, there was the accompanying editorial, and they basically said this, we're still looking for GEP data. Does this test help us figure out who we can not send for sentinel node? And it said, no, it didn't answer that question.
Wasn't good enough.
Right.
Okay.
That was the thing. Now, again, this was in JAMA surgery. This is done by surgical oncologists, editorials by surgical oncologists. They still very much believe that sentinel node biopsy prevents progression in that lymph node basin. And there's data, if you look at post-hoc analyses, do support that. But I don't think that they're looking for a reason to use GEP in general. But yes, this study did not give it.
So the vaguely related things I wanted to talk about. So first, there was somebody in my office this week who they now have a commercially available circulating tumor DNA test, which you guys maybe already knew this. So like if you want it, you send the path report to them. They get the tumor specimen from the path lab, come up with like, here are its genetic things, and then you send them some blood and they're able to, I guess, do a very sensitive analysis for circulating tumor DNA to give people more prognostic information about residual disease. Now you apparently got to wait at least a month after the surgery, because doing the surgery on the tumor releases all kinds of tissue of, circulating DNA. So you don't want to pick that up. So you got to wait at least a month, but I have no idea what it costs or if it's available, or I didn't go into any data at all, but it was just interesting to me that it is now commercially available.
Some centers are doing this and using it. It's not totally clear, exactly. We don't have great studies. There was a adjuvant mRNA vaccine study where they looked at ctDNA in patients. And they did find that higher levels of ctDNA were predictive of lower survival. And, there is evidence that it's like it sort of varies with tumor burden, right? So if all of a sudden your ctDNA is going up, that's probably a reason to do imaging and think about it. But it's not firmly in the guidelines, but I think it's very interesting.
Yeah. The other thing, I got an email today. So I get, I don't get colonoscopies, I get Cologuard, where you poop in a bucket and mail it in, and they tell you if you're high risk for colon cancer. Well, Cologuard now has a thing called Cancer Guard, which is a blood test that detects 50 plus cancer types and subtypes with one blood draw. Obviously, it's not covered by insurance, but it's like $689 to get it done. And I was just like, man, I don't want that done. It seems like it's gonna, again, it was just weird. Like, well, wow. Okay. Now we've got blood tests. Okay. You're cancer free. Like, the amount of testing that this seems like it's going to drive, it seems like it's going to be.
I was doing that study in Pittsburgh for the Grail Gallery test. So just because we had a clinical trials unit and lots of patients through, and so it's multi-cancer early detection. You're basically looking for, circulating tumor fragments that they can then put back to a certain, class. Mm-hmm. And so it is for detection. And then, the study was to follow how often was their cancer, and then also follow the negatives to see how often those people did develop tumors. It was also looking at things like adverse events from, additional testing and what additional workup was done. It was really interesting. I did have one patient who came in to me and said oh, I put him in. He was like I don't know, psoriasis patient or something. I put him in, and then I got back a positive like anal cancer signal. And so I was looking through his chart, and I saw I'd been seeing one of the GI PAs for treatment of hemorrhoids, and they kept bleeding, and he kept going back for his bleeding hemorrhoids. And so I called him and I said, I actually would like you to go, like, I'm going to call your gastroenterologist. And they went in and they biopsied it. And what was being treated as a hemorrhoid was actually like a friable tumor. So he actually did have the tumor, which was, unfortunate. So, things like that happen, but there's also, false, like some false positives too.
How was the Cologuard cancer test? They would just mail you it directly. It wouldn't go through like a doctor or anything.
Like
they mail you the test.
The cancer test I'm talking about?
Yeah.
I think you can have your doctor order it, or you can get a telehealth and they'll order it. And then you go somewhere and get it drawn and mail it into them.
Yeah.
Yeah,
it's just going to drive oncologists kind of crazy, right? Well, oncologists are going to have these, find my cancer.
Well, Ohio State University, now they advertise it on TV, has like a whole unit dedicated to like, I think I have cancer. And they're like, we'll get you hooked up with oncologists and we'll scan your whole body and we'll do like they advertise it like an Ohio State Buckeye games. And I'm like, it's okay. I think I got cancer. I'm coming in. Like,
wow.
Yeah, I don't know if there's like a heavy duty screen, like if you've got to get a referral from your primary care doc that's like, oh, there's a shadow on your, lung, your chest.
No, I think those are truly for asymptomatic patients, but they are supposed to be ordered by a physician and they're only supposed to be done you don't want to give that to a 20-year-old, it's certain ages and things like that. You're old enough though. Don't worry.
All right, next, what do you got, Ferris?
No, that was me. I'm done.
Oh, that's right. Circulate. That's right. Now, Pat,
only
what do you got?
do like 50 bazillion papers. So yeah.
My second Six Packs article from October JAD titled Efficacy and Safety of the Oral Janus Kinase Inhibitor Povorcitinib in Patients with Extensive Vitiligo in a Phase 2 randomized double-blind dose-ranging placebo-controlled study by Amit Panja et al. So it was exactly that, non-segmental vitiligo. Study design was in the supplementary materials. It's not labeled correctly, but basically randomized placebo and then 3 different doses of povorcitinib for 24 weeks. There were about 40 patients in each group. And then everybody got povorcitinib up to week 52. The 45 milligram group stayed on 45. The placebo 15 and 75 all went to 75. And that's where it's mislabeled because it says that they went to 45.
Okay.
So that's not right. Yeah. Primary endpoint, change from baseline in the total VASI at week 24. And all of the POVOR patients had improvements in T-VASI. Percentage improvement was almost like 20% improvement in all the doses. And this improvement continued through week 52. Similar improvements were seen in the face VASI scores, all doses showing statistically significant improvements compared to placebo at week 24 with continued improvement at week 52. Were these clinically meaningful differences? It's hard to say. The key secondary endpoint was the total VASI 50. So this would be like 50. I mean, the way I'm reading this, 50% improvement in repigmentation. I mean, like that would be the very least a vitiligo patient would want to have, I would think. And at week 24, no statistically significant differences in the percentage of patients reaching this endpoint, whether you were on Porvo versus placebo. It was numerically higher for the Porvo people. But yeah, it didn't reach statistical significance. There's this whole table in there that looks at the T VASI 50, 75, 90 and the F VASI 50, 70, 90. It's a ton of numbers, and I don't think we can meaningfully go into all the data. If you looked at, let's say, like the face VASI 90, so you got 90% repigmentation in the face. And I think that's what a patient with vitiligo would very much like to have. I mean, obviously they want to have 100%. But if you could tell them your face is going to be 90% better, I think they'd be like, okay, yeah, I think I'm going to do this. So in the highest dose group at week 52, so basically patients that were on 75 milligrams a day for 52 weeks, only about 30% of patients reached an F VASI 90. And it just doesn't like seem that good. But, vitiligo patients on the face, they may be happy with that sort of improvement. There are some patient-reported outcomes that the supplementary materials had. I mean, again, it's just a ton of charts. The facial patient's global impression of change I'm going to put that one in the slideshow. For the highest dose, patients on 75 milligrams daily from the beginning of the study, 69% of patients reported very much improved or much improved after a year. That kind of seems good. It's just really slow. Percentage of patients at 6 months with the same scores was something like 22%. So at 6 months in, you're not going to have a lot of people that are like, hey, this is much improved or very much improved. And then what had to be the most disappointing results were the quality of life measures, vitiligo specific quality of life, DLQI, some other ones. And there were no meaningful improvements in any of those. Takeaway vitiligo is hard to treat, and nothing really jumped out like on the safety data. Typical stuff you see with JAKs. What did you guys think?
So quality of looked not great, and so the quality of life stuff said nothing. Wow.
Right. I think this is going to be a like using combination with narrowband or other things, right? Like,
I think so too. Yeah. I mean,
even there's been some data looking at it with narrowband, and it wasn't that much better. Not Pavro in particular. I think this was Tofa.
I thought the Berry data, the Berry study we did, Berry, and then
maybe it was Berry.
Narrowband alone, narrowband plus Berry. I thought those patients did better.
They did.
Yeah, I think that they do. And then, I don't know. Anecdotally, like I've kind of done that, or eczema laser, which is, basically narrowband. And then
like
polypodium leukotomas. There's some data for adding HelioCare when you do like to narrowband for treating vitiligo. I will say anecdotally about a couple times I felt successful, and it was polypodium and narrowband, and then some sort of like topical JAK.
Yeah, I mean, the ruxolitinib data. I think I think it was the Rux data. Their primary endpoint was the F-VASI 75. And for this trial at week 24, topical Rux actually did better. Higher percentage of patients that reached that F75, but at 1 year, 52 weeks, it was about like 50% in both the topical Rux group and as well as this oral Porvo group. About 50% reached that F-VASI 75. And I think topical Rux is like pretty good for vitiligo. I mean, they have to stay on it. They have to keep using it, and it's going to be slow. But right, I've had patients where you give them that because that like topical steroids for atopic derm. I think I can counsel patients use it on and off, and that's fine. And here's when you do use it. Here's when you don't. Like vitiligo, there's no break. If you're using a topical medication, it is every day forever until you start to get that repigmentation, and you just can't do that with steroids. That's why I like the topical calcineurin inhibitors, because they could use those forever. And that's why I like the topical JAKs, because just like use it forever. It's fine. And combining it with narrowband and maybe some other things that are out there, I think it'll be nice. It's just, systemic JAKs, I think dermatologists are a little bit wary of prescribing them. And I just don't know how willing they're going to be to prescribe something where it's going to be slow. A fair number of patients are going to be like, this isn't any better. It's tough. Like that's going to be a tough indication.
Yeah. It's going to be, it's like, and right, you can add on, right? There's data for Plaquenil. There's data for PDE4 inhibitors. There's actually some data for Vitama. And there might be like, if you combine Vitama with Opzelura, maybe it's even better, but you'll obviously never get that covered. The other thing that can be interesting, there's some data for using latanoprost. So like the eye drops there, and that's cheap. Use that once a day and your Opzelura twice a day. And it seems to make it work a lot better by stimulating the melanocytes.
Yeah, I've seen people talk about, and I'm not like a microneedler, but microneedling bimatoprost onto areas of vitiligo. I actually saw a paper once for like microneedling 5-FU, which seemed crazy to me. But like, I think there's probably different things we could be.
It's hard disease.
If only I were that interested in it. Yeah.
Hard disease.
Hard disease.
Right. Yeah. All right. Let's move on to my last couple. So we've got number one. I mentioned this in last week's episode, topical timolol for treatment of spider angiomas in children, a case series. basically they treated 6 spider angiomas twice daily for 6 to 13 months. 2 of them went away completely. 2 of them got a little better. And whenever you look at the picture, like they got a little better. And then 1 of them had no response. So, this can be something if some parents come in with a kid with a spider angioma, maybe it would work in adults too. This is something cheap and easy to do. Topical timolol is dirt cheap. Dab a little bit on there a couple times a day, and maybe it'll help. Or I think a lot of times people are okay with leaving them alone, but if they want to do something, this gives you something to do that is easy, right?
A solution looking for a problem.
Yes, but it's a cheap solution though.
Yes.
Cheap.
Looking for a minor problem. So it's good. They're a perfect match.
It's good, Ferris. It's good. And then the other one, this was interesting. So, title of this article was Demodicosis mimics acneiform eruptions in patients with inflammatory bowel disease receiving upadacitinib, a case series. So basically, they had 509 inflammatory bowel disease patients. 30 of them got acneiform eruptions. And of those 30 who got acneiform eruptions, 20 were Demodex were caused by Demodex. Now, here's where it gets super interesting. Of the 509 patients, 181 got biologics, not, let's see here, 1 patient got a Demodex in that group, right, out of 181. 308 people with conventional therapies, 2 of them were diagnosed with Demodex. There were 18 patients treated with Rinvoq. 16 of the 18 treated with Rinvoq got Demodex. Like 90%.
Maybe that's what Jacne is. It's just Demodex.
That was exactly my whole thing in seeing
all right.
this.
From now on, we all, for the next month, are going to scrape every Jacne, see if there's Demodex.
See if there's Demodex in there. And even if we don't see the Demodex, maybe you just give them a few doses of ivermectin.
Yeah.
See what that's because this is, I will tell you, I am a believer that all papulopustular rosacea, or at least, I don't know, I'm not making that up, that a lot of papulopustular rosacea is Demodex driven, even with a negative Demodex prep. So my go-to for somewhat resistant rosacea is combined oral ivermectin and metronidazole. So you do ivermectin 1 milligram per 10 pounds, repeat it in a week. The same day that you start the ivermectin, you start oral metronidazole, 500 milligrams twice a day for 14 days. And that is stunningly effective for rosacea, like papulopustular. Doesn't do anything for just erythroid, telangiectasia, blah, blah, blah. But for the papulopustular, super effective. I think of Demodex as one of the most underdiagnosed things out there. So I'll do the ivermectin metronidazole orally and then follow it up with the compounded ivermectin metronidazole azelaic acid from one of the compounding pharmacies as maintenance therapy. And that's but that's what this article made me think about, was that Jacne maybe is Demodex.
Yeah.
I think that Demodex is going to be diagnosed more frequently because now they're advertising the eye drop. Have you seen these commercials?
No.
Like they're on in football all the time. So there's a little woman dressed up. Like, how'd you like to be that actress? Like, I got your perfect job. What am I? You're a mite.
You're a Demodex mite.
She's in her little mite costume, and then they splash the things on, and all her friends disappear, get washed away. So I think people are going to be like, hey, I saw this commercial with these mites that can be living on me. What do you have for me?
Maybe. We should just deworm humans like we do
it's not
with
bad.
dogs and horses. It would probably be good.
Patton, what's the active ingredient in that eye drop?
I'm pretty sure it's ivermectin. I don't know.
Okay.
Hold on. Let me find out.
Yeah. No,
you guys talk amongst yourselves. I also like this paper. They said that we obtained the samples using the thumbnail squeezing technique Like that's a thing we all.
That's
Yeah, I
so
guess.
mean. No, you know what? You, I think, taught me this. The best way to get a Demodex prep is to use a comedone extractor, and you just push on the pustule, or even just on a red juicy papule, get a little oil and put that on there. That is by far the best way to extract
Oh,
Demodex.
that's useful. I always
Yeah.
do it
Yeah,
with. I use 2 glass slides and like use the 2 of them to squeeze a pustule and like let it pop, but it hurts like hell.
Oh yeah. No, do the comedone extractor. You just kind of
like
rub it over.
Squeezes them out.
Yeah.
Yeah, it does. It really
So-
does work well.
Xdemvy is the name of the drug. Xdemvy ophthalmic solution. The active ingredient is lotilaner. Lotilaner, I don't know. It's a GABA-gated chloride channel inhibitor that paralyzes and kills mites
Huh.
Mm.
without
Maybe we will
affecting
see-
humans, which would be a bad thing if it
Yeah,
also
paralyzing.
paralyzed and killed you.
Can we inject it and
Yeah,
it'll make wrinkles
that
go
is-
away?
I don't know.
No, because it
I
doesn't
don't know.
work on
If
us.
it's paralyzing things, that's always what first thing that comes to mind. Could it?
I was
Yeah, sure.
thinking head lice, and we
Yeah.
could use it for that.
By the,
Yeah.
I'll put that out there too. That's another thing. If for head lice, you can give people massive doses of ivermectin.
Yes.
There's a
Yeah,
fair amount
there's
of
a-
resistance now, but that's another possibility.
New England Journal of Medicine good trial of that years ago, I think. I think it was New England Journal of Medicine. Yeah.
Okay.
No, that is a favor of somebody who has treated head lice in children before.
Yeah.
I sure would prefer a pill because I can't smoke when I put malathion on them. That makes it worse.
All right, that's enough. So I want to thank everybody for joining us this week. I hope you learned a few things. Hope you laughed once or twice, and mostly I hope you're planning to join us next week. Until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.